All right, thank you everyone for joining us today for the, I believe we are the 6th meeting of Health Services this session. So we have a very busy agenda. We are going to go ahead and get started. DJ, please take the roll.
Representative Bratcher. Representative Bray. Representative Burke.
Here.
Representative Callaway.
Present.
Representative Camuel. Representative Dotson. Representative Fleming. Present. Representative Gordon. Representative Holloway.
Here.
Representative Marzian. Representative Neighbors.
Here.
Representative Proctor.
Present.
Representative Rayburn.
Here.
Representative Raymer. Representative Riley. Here. Representative Sharp.
Present.
Representative Wilner.
Here.
Vice Chair Duvall.
Here.
Chair Mosier.
I am here. We have a quorum established to do business, and we will go right ahead and get started. The first bill that we will consider is House Bill 14. 414. What did I say? 14. 414. Sorry, it's already been a long day. All right. And I believe that we have Dr. Jeff Goldberg on Zoom. Okay.
Yes, can you all hear me okay?
We can, thank you. So I'm going to have everyone at the table introduce themselves, and then you please introduce yourselves for the record and proceed with the description of the bill.
Great. Thank you. I'm
Thank
State
you.
Representative Nancy Tate, and I represent Meade and Hardin counties.
Jason Nemus, I represent Jefferson, Oldham, and Shelby counties.
Thank you. Adia Wishner, registered nurse and executive director for Kentucky Right to Life.
Thank you.
And Jeff Goldberg, I'm a gynecologic oncologist, and I'm the legislative advocacy chair for the Kentucky section of the American College of Obstetricians and Gynecologists.
Okay, thank you so much for being with us today. We do have a committee sub. I will entertain a motion on the sub. We have a motion and a second. All in favor of adopting the committee substitute 2, please say aye. We circulated it as soon as it was ready, yeah. So, but we're going to go ahead and talk about the committee sub. There's flexibility this time of session. Thank you. Okay, please proceed.
Yes, Madam Chair and members of the committee, I sincerely appreciate the opportunity to talk about House Bill 414 with the committee sub. This is a subject that we've talked about several times before, but of course with the committee sub, this gives us more flexibility. You know, I like to talk about it as far as like, you know, Momnibus was one of our great bills last year, and it just played into some of the expanded language that we had for caring for mothers with some of our insurance and the capabilities that we had. So I think this is just like phase 2 or phase 3 of the Momnibus, and it gives us the opportunity to provide additional care for women and their families in the event that they have a pregnancy that turns out to be not exactly perfect. So, you know, for the sake of time, and I know you've got a really tight schedule, I'm going to turn it over to Dr. Goldberg and, of course, Adia Wishner for their testimonies.
First of all, on behalf of Dr. Goldberg and myself, we want to really thank the members of the committee and the chairman for hearing this piece of legislation today. And additionally, we want to recognize Representative Tate, Representative Mosier, and Representative Nemus for extensive work that has been put forth on this measure that we brought forth. So I think last week the committee did have an opportunity to hear the provisions of House Bill 414 as we talked about palliative care. And the committee sub includes language that has been much needed to clarify medical standards and treatment, and working alongside of Kentucky ACOG to make sure that the women of Kentucky have the care that they need appropriately and that the physicians are able to care for them. And Dr. Goldberg's going to speak to that in just a few minutes. So there's been a lot of misinformation, a lot of concerns and fear out there about what can be done in the medical practice. So jointly we've worked together to put those fears at rest and make it clear. And so as we look at right now, although we've always said that current law does not restrict medical care for miscarriage management, ectopic pregnancy, molar pregnancy, sepsis, hemorrhage. These are some of the most serious complications that can occur in a pregnancy. And many of these interventions would require emergency treatment. So the assurance, and I'm going to ask Dr. Goldberg if he'd like to speak at this point, is that these areas of care for women in the Commonwealth of Kentucky will be able to be addressed in the medical community without concern.
Sure. So I think I would preface my remarks by emphasizing that we've been able to have really good discussions about things that we're in agreement on, as opposed to things in the past that we might not have been in agreement on. And we're all in agreement that the current situation for caring for women in the Commonwealth who have complications of pregnancy is in a terrible state. While it may not have been the intention of the legislature when writing laws either restricting elective abortion when it was still legal or subsequently making it against the law, may not have been the intention of the legislature to make it difficult to properly care for women who have pregnancy complications that have nothing to do with elective abortion. Nonetheless, that has been the outcome. And it really stems from the fact that when you try and write laws for something as complex as the practice of medicine, the language that may be used in statute may have one intention when voted on by the legislature, but simply does not fit with modern medical practice. Without going into too much detail, because I know we're limited in time, I will just tell you that current statute has a tremendous amount of ambiguity. There are medical conditions that are well known to physicians that were not foreseen by the legislature. There is still a great deal of work to be done in this area, but we are in the closing days of this legislative session. And so we have come together to work on parts that we think from a political standpoint can be managed in the short term, with the understanding that there's a great deal of work that still needs to be done on cleaning up the current statutes, clarifying ambiguities, and handling issues that were not properly dealt with under the law. Again, this has nothing to do with the current restriction on elective abortion, but rather the unintended consequences for treating things like miscarriages and ectopic pregnancies and conditions that most people have never heard of, like gestational trophoblastic neoplasia or preterm premature rupture of membranes, or things that the average layperson, fortunately, would never need to know about or experience, but nonetheless, the management of which has been very complicated and inhibited because of current language in Kentucky statute.
Okay, thank you. And I do want to clarify that we are speaking to the committee sub. I think I got interrupted a little bit when we were approving that. So it is approved.
Excuse me, sorry.
I wanted to add, Madam Chair, just to be clear, as those of you that are looking at the bill before them, what we have done is we have defined into law, should this pass, what is not an abortion in the Commonwealth of Kentucky. And so all of these prescriptive medical treatments that you see before you are written into the bill using the medical terms. So when you see spontaneous abortion, not to be confused with an intentional abortion, but those are the correct medical terminology and medical nomenclature. So, and when you see fetal demise, it explicitly says removing of an unborn dead child from the womb of their mother, which would be, as we would think of it, as a stillbirth. So it's been very well thought out in collaboration with ACOG so that these areas could be addressed without question.
Thank you.
I would want to emphasize as part of my testimony, just for the record, nobody is holding this up as perfect. There's going to have to be some compromise. There are a lot of nuances that we simply did not have time to have discussions on. We're simply trying to ensure that on a day-to-day basis, doctors feel comfortable providing evidence-based care for women with complications of pregnancy that, again, have nothing to do with elective abortion. These are simply conditions that occur that have gotten caught up in our current statutes. And, without getting too graphic or emphasizing the point too much, these are conditions that are life-threatening. And yet it's not always explicitly covered under our current statutes that they're life-threatening enough to permit the kind of care that evidence-based practice requires. So we just want our treating physicians to feel comfortable handling routine complications of pregnancy and other conditions that come up that, again, have nothing to do with people seeking elective abortion, but without fear of the severe penalties that have been attached to providing elective abortions.
Okay, thank you. I'm going to speed things along here a little bit and allow Adia. Do you have anything else that you wanted to discuss?
I think we've addressed everything that's included in the committee sub. Yes.
Okay. And then the committee sub did remove the insurance provisions
yes, ma'am.
for the palliative care.
That's
That was
correct.
part of the original bill.
That's
Yeah,
correct.
Okay.
It did, in fact.
All right. Is there anything else that you would like to add?
Nope, at this time, I'm open to questions.
Okay.
Thank you, Madam
And
Chair.
then Representative Nemus?
No, I would just say how this came about. ACOG reached out to me and we started down this line. I didn't think it was going to be possible given the subject, but we have people who don't always trust one another, who've looked each other in the eyes, who've come up with this really good bill, I think, that will save women and it will save babies. And that's the point. A lot of people from all sides of this debate probably want to go further. I respect all those positions. This is solving a discrete problem and it will save the lives of mothers. We have Dr. Goldberg, and he's the one who started this conversation with a phone call to me in the summer. And I'm very proud of the work that we've been able to accomplish. And I'll invite my friends, both who disagree on other things, to join us here and save the lives of mothers and children.
Right. Thank you so much. And I would agree that this is simply a clarification of the medical necessity for crisis pregnancies. And so you've all done a good job of explaining. I don't think that I can add anything. So we do have a couple of questions. Representative Wilner.
Oh, thank you, Madam Chair. I do appreciate people with different views coming together. I'm always a fan of that. And I also live in the world of reality. And I know that I personally believe that abortion access is entirely between the pregnant person and their provider. And I know that my view, there are others on here that share it, but I know that it's a minority view on this committee. So I live in that land and I understand it. But I think there's one piece in here that I think really all of us ought to be concerned about. And Dr. Goldberg said in your testimony, sir, if I heard you correctly, that currently we have no restrictions on miscarriage management. But the way I read it, and I'm looking at the sub, I'm on page 8, and I'm specifically at section 3, subsections B and C, lines 9 through 15. And we've heard stories from around the country, and I think it's what you guys are trying to address, of women starting to miscarry. There's fear about, there's lack of clarity. What can I do? Can we intervene? And women have died. And so currently we have no restrictions, but this seems to me to add a restriction to codify that a woman, a pregnant person, has to be basically at the point of death, hemorrhaging, in sepsis, and at that point the doctor is free and clear to treat them. Again, too many stories of women suffering, their physicians afraid to treat them. And I think that this not only, I think the effort was to add clarity, but I think what it does is to codify that a woman has to suffer a lot before the doctor is given, in this language, before the doctor is free and clear to treat to manage that.
Well, not only that, she's missing that. Yeah,
to
she's
manage
missing-
that. And further, it seems to me that it's really prescriptive how the physician needs to manage that miscarriage, as opposed to leaving it to the expertise of the attending physician or other healthcare providers who are in this situation. And I understand that we have real differences in philosophies. I get that, but I think, especially given all the whereas clauses at the beginning and the affirmation of life, nowhere in affirmation of life should we be codifying getting to the point of suffering before you're able to get treatment.
Yeah, Representative Wilner, Dr. Goldberg, please.
Oh, am I okay to go and address
Yes,
that?
please. Yes, please.
Okay, yeah.
I would prefer.
First of all, let me be clear. The language in this committee sub is not meant to be perfected. If the legislature was willing to sit in session year round, if our Constitution permitted it, we would just keep working on this and bring it back to the committee when we thought we had it perfect. But we live in a system where we have a 30-day session this year. We have a few days to get some good done as opposed to getting everything perfect. These conversations took place with the understanding that this was the very start of a much longer process of going back and identifying numerous irregularities in the statutes that currently exist. And there's still a great deal of work to be done, but I think we've been able to establish some trust with all the parties you see in front of you that we're going to continue with that work. In terms of adding additional restrictions over and above the current environment that we're in, we already work within statutory restrictions that are, from a medical perspective, very ambiguous. For example, we are allowed to perform pregnancy terminations to, quote, preserve the life of the mother or to prevent a high likelihood of loss of a major organ function. That might sound clear-cut to some people who say voted for this legislation, and yet when you come into the medical side of things, it's about as clear as mud, because there is no definition of what is a high enough risk to meet the statutory requirement. So there's still a great deal of work to be done in refining that language. At present, this makes clear, as best we've been able to put together in a short time, that routine care for things that have nothing to do with elective abortion, that's again, miscarriage, premature rupture of membranes, preeclampsia. I don't have time to give you an exhaustive list, but the idea is if it doesn't have to do with an elective abortion, then doctors are permitted to provide evidence-based care that is supported by the medical literature without fear of being charged with a felony. Because the current environment that we're in, and I'll give you an example just so everybody's clear. I have a colleague who had a patient with an ectopic pregnancy that was located in the cervix that still had a fetal heartbeat. And so under the current statute, it was not at all clear to him that he could proceed with properly treating this patient. As it was, because it was located in the cervix, it bled profusely. She wound up getting blood transfusions that were completely avoidable if she had been able to receive proper treatment. And fortunately, she did okay long term, but that's just a typical everyday example of how statutes that were thought to be clear by the legislators were not at all clear to physicians who are treating patients on the front lines. So we see those kind of things come up every day. And you've seen news reports from other states where similar statutes have led to situations where patients have unfortunately died from complications that could have and should have been treated, but because of the legal environment, physicians felt inhibited from doing what they knew was right based on the medical evidence. So there's a great deal of work to be done. This is not perfect. I don't want to leave anybody with the illusion of we all think this is great. We think it's an acceptable short-term solution for dealing with a really serious problem that's in front of us.
But
Okay.
but I would note
Go
it
ahead.
is a big step forward. The situation that Dr. Goldberg just identified would not have occurred that way had this bill been enacted. And so yes, it's not perfect. We'll continue to work on it. Rome wasn't built in a day, but this is a first really good step forward where both sides, if you want to say both sides, have come to the table and tried to work out some an agreement where we have in an issue where we have serious disagreements.
Right. Thank you. And I would just point out that this still is based upon a physician's reasonable medical judgment. So, it's tough because we knew that if we tried to start naming procedures and reasons, that it's going to look overly prescriptive. So, this is a step in the right direction for medical clarity. Okay, so we have Representative Marzian.
Thank you, Madam Chair. My question is for Dr. Goldberg. Where does national ACOG come into this? Are they supportive?
This is a very unique situation. I actually just got back from Washington, D.C. last night and have had an opportunity to spend some time with a lot of my colleagues who fill the role that I do in this state, but in other states. And we, as everyone knows, we live in a very divided political climate. Most of my colleagues are in states that are either very liberal Democratic leaning or very Republican and socially conservative leaning. And this in between that we're seeing, where we have two sides sort of working together, as Representative Nima said, is kind of a unique situation. So I think there's a lot of suspicion and wariness, unfortunately. But at the end of the day, we focus on the commonalities that we have, which is regardless of our feelings about elective abortion and the reasons for it and the role of government in making those decisions versus a woman and her doctor. One of the things that we do share in common is none of us thinks that it's okay that patients with pregnancy complications are being harmed because of the way that the law was written. That we all agree on. And it's going to take a lot of untangling to fix that. And because we don't have a year-round legislature, we have to do what we can in pieces. So, we focus on what we can accomplish in this 30-day session, and then we're going to come back at the next legislative session and work on the rest of it. There is no model, unfortunately, in other states. We are, I think, leading the nation in terms of trying to compromise on some of these issues. We've seen other states where, in Alabama, for example, the legislature had to quickly come in and clarify that anti-abortion statutes did not apply to in vitro fertilization. But mostly other states are still struggling with this issue. So I'm hoping we can serve as an example to our national organization of how we can resolve some of these issues and promote better health care for our pregnant patients.
Okay, so I guess as of now, National ACOG is not supportive of this. And I had one other question, and it says...
Would you like to ask another question?
Just one other question. Thank you, madam. So it says they shall offer services. Can the woman say, no, thank you?
Palliative care.
Yeah, as far as palliative care, yes, the services are optional for the woman and her family to decline.
Okay, thank you. And Representative Burke.
Thank you, Madam Chair, and thank you for bringing a bill that is thinking about the well-being of Kentucky women. I have a question about the process by which this bill has been put together. I wondered, so this any one of you could answer this, were any hospital general counsels involved in the drafting of this bill?
No, it was, to my knowledge, Dr. Goldberg was involved, and so were the others at this table and Representative Mosier.
I would say, as a former hospital administrator in the past, much of what we took into consideration was how general counsel for a hospital, how things, and Dr. Goldberg, we spoke about this a lot. A lot of times it's how the hospital's attorneys are viewing things. And so that's why we wanted to make sure there was no ambiguity in the law so that the physicians could take care of their patients, and that this was going to be moving forward the best we could do for maternal health here in the Commonwealth of Kentucky.
And having hospital attorneys is important. I agree. I'd like to hear their comments, but we have the head of Kentucky ACOG was the principal mover behind this. He was the catalyst when he made the first phone call. And so I don't think anybody is more expert than Dr. Goldberg is.
Thank you. May I ask one follow-up question?
Yes, quickly.
I think Dr. Goldberg was going to say.
Maybe he respond.
I was just going to say, without bringing any legal confidences, this information was shared with legal counsel for at least one large institution that provides a number of deliveries, and they were invited to these conversations. They chose not to participate, but there was by no means any intent to exclude those stakeholders. And again, this was put together in a 30-day session in a very short-term environment. Our goal going forward is to have a much broader effort that will include more stakeholders.
Thank you. And may I, with one additional question?
Sure, quickly.
Thank you. In the spirit of trying to make things clearer, I'm wondering why we are creating new language instead of just calling it what it is. When there's an ectopic pregnancy or a pregnancy that is in crisis and the woman is going to die, why do we need to call it separating the mother from the unborn child, and just instead of calling it an abortion? Because that's what the doctors call it. They're not going to call it separating a mother from a child.
You know, the term, and I already mentioned spontaneous abortion for a miscarriage and a topic, we wanted to make it perfectly clear because that's where it seems to be confused, that there was an assumption that these procedures that were much needed for women would be seen as performing an illegal abortion. So the terminology, when it is not an abortion, when these medical conditions make it necessary to separate the woman from her unborn child, is to make it perfectly clear so that the medical community is not hampered by how the law is being interpreted. So that's why it's a special section to say, this isn't an abortion. These aren't abortions. They use that term, but they're not intentional abortions. And we just wanted to make sure to take whatever the constraints, the fears, the uneasiness there's been, so that the women in Kentucky can have the maternal health care that they deserve and that's much needed. I hope that helps.
Thank you.
Again, I don't want anybody here to be disabused of the notion that this language is perfect. You know, if you are concerned that there are ambiguities, I will tell you right up front, there still are. But we can do some good in a short amount of time, or we can do no good. And given those two options, I would rather choose the former, with assurances that we will come back and continue this process.
I do want to note that with respect to the language that's mentioned, people may choose other language, but there's no ambiguity there. Everybody knows what we're talking about. You might use the word abortion rather than separating the pregnant woman from her unborn child, but there's no ambiguity there. The docs in the hospitals, they'll know what we're talking about, and that's the most important thing.
Right, and that's the whole point of this, is medical clarity.
That's exactly
Okay. All right. Representative Camuel, and then I have two people who have signed up to speak.
Thank you, Madam Chair, and thank you all for bringing this bill and trying to come up with a solution to a problem that, in my mind, doesn't really exist. But that being said, I do have a question. Actually, I've got a couple, but the first one is, let me ask you this. As a Jewish woman, I think perhaps the only Jewish person, well, actually, I think we've got some folks that have Jewish heritage as well, at the table. My religion, my beliefs, my tradition specifically states that I have the right to make the decisions about my body. And should a pregnancy result in a medical emergency, if the life of the mother, the mental health, the well-being, if any of those are threatened, or even by choice, that I should have that right. I don't see any religious protections in this bill, anything that says if this is what your religion says, that you're covered, that you're okay to proceed as your religion directs you.
Yeah, look, I want to answer that if I could. That's a discussion we can have continuously. We've had it before. We can continue to have it. That's not this bill. I don't want to, with respect, I don't want to get off and talk about every other issue on abortion. We can talk about 1,000 things, and people can have impassioned views on it. We have a discrete issue we're trying to solve here. We're trying to save women's lives when they've presented with extreme difficulties in their pregnancy. We can have debates on other things. That's what this bill does. And so we're not going to add other things. We've got, I think, good language here. We're not gonna discuss ancillary matters. Even though I respect your,
I do
your
not
views.
feel that's ancillary, but I understand.
I understand that, but so I want, if I can, keep the discussion to this discrete issue that is a real issue. I know you said you don't think it exists. I think you meant to say you don't think it should exist because you think there should be more abortions. I think you would acknowledge it does exist. The issue with women presenting and doctors being confused on what they can do. And so we're trying to resolve that issue. So please, if we could, I'm only one in 138, but if we could just keep it to that discrete issue, that would be my request. But I'm only one member of 138.
May I ask another?
Quickly.
Thank you. I appreciate it. Liability-wise, looking at this bill and looking at the language, what happens if medical care, there is a medical emergency, a woman is presented with, she's bleeding out, she's septic, whatever the case may be, if there is a delay in care, in what we know is the best practices that could have been taken in order to save the life or perhaps the fertility, the future fertility of the mother, who's liable for making the decision or failure to act in a timely manner that costs the life or fertility?
Well, I think Dr. Goldberg is on, but there would not be a delay. This is making sure that one, there's a provision for a total emergency in the bill. There's a clause, but this is making sure that she has all the care. There's no delay that should be in the thought of the provider that would not cover her care. And especially when you're talking about sepsis or bleeding or hemorrhaging, that is a medical emergency that would be cause immediately to be addressed. I think Dr. Goldberg, who would be the medical expert on that, is still with us.
Yeah, so just to be clear, the conditions you're concerned about exist today, and they have existed ever since the trigger ban went into effect. I mean, I know recently a patient who was waiting in the preoperative area with a large amount of blood in her abdomen from a ruptured ectopic pregnancy because the anesthesia team would not take her back until the forms required by the hospital attorney had all their I's dotted and their T's crossed. Now, again, fortunately, she did well. And I have, colleagues who treat patients every day across the state who present, for example, with ruptured amniotic membranes, which nearly always leads to serious infection and loss of the pregnancy. But they are concerned under the current statutory language because of the ambiguity that their patient is not seriously infected enough to go ahead and induce the end of the pregnancy. So this again clarifies that treatment of those conditions is not considered elective abortion, that the penalties attached to elective abortion do not apply to evidence-based care of those patients. Is the language perfect? No. Does it need more clarification? Absolutely. Who's liable? The doctor, okay? In every case, and regardless of the statutory language, the physician treating the patient is always legally liable for those outcomes. The problem that we have today is there is tremendous conflict. We call it moral injury. Tremendous conflict between a patient's duty to care for that patient in the best way we know how and the threat of being charged with a felony if some rogue attorney or some rogue prosecutor doesn't think that we made the right medical call. That's the situation that we're trying to fix. And again, I want to emphasize this is the start of a fix. This is not the entire solution.
Okay, thank
Thank you.
I'm going to ask our guest who signed up to speak. Are you here to speak on the committee substitute, Dr. Stokes and Dr. Rigby? Okay. You want to come on up, and I will give you each 3 minutes to state your case, and we will proceed. Just come to the table, find a microphone, make sure the green light is on, and introduce yourselves for the record. And you decide who goes first.
Same for you.
Okay.
There you go.
Okay. Yes, my name is Virginia Stokes. I am a board certified OBGYN physician. And, I think this is a conundrum because we wouldn't need to be deciding if this bill was adequate if we'd never instated the first bill to begin with. nonetheless, as much as the ideals he espouses sound very good, he still haven't solved the problems. It still has you waiting on death's door before you're allowed to get medical treatment. And I have to stand there and watch it happen. You can't fix sepsis once it starts. It's not an easy thing to do. I'm also concerned because he himself, Dr. Goldberg, was describing medical expertise and research-based treatments, but when then they wrote the bill, it says something, what is the word? Reasonable medical judgment. I can't go to court with that as my defense. If I make a scientifically researched medical decision and somebody else decides it's not reasonable, you have to take that out. I can't go with this bill with that in there. I can't. I mean, I actually myself still do a little bit of locum tenens, and the last time I worked in a rural hospital in Kentucky, I had a weekend full of second trimester complications that put me at risk medically. I went home, called them back, said I'm not coming back, and I haven't been back, and it's because I was afraid that the sheriff was going to show up at my door all month long for the normal ACOG accepted reasonable treatment of second trimester complications. So I don't know how to say this. This is a great idea. The best idea is to get rid of the dang law to begin with. And then the second case would be that you would learn to trust the physicians you are raising up in this state, in Kentucky and across the United States. The medical schools are being taught morality and judgment and law, and they know the difference. They know where the line crosses, and between the patient and the physician is all it should ever amount to.
Okay, thank you. And on page 7, we did define as best we can, and I know it's a little bit subjective, but we're trying to interject the reasonable medical judgment to be the range of conclusions or recommendations that licensed medical practitioners with similarly sufficient training and experience may communicate to a patient based on current available medical evidence. I welcome your suggestions, and but today we're trying to clarify what we have heard are difficulties in the medical community.
Right.
And, this is a step, and I understand and I respect your position, but right now we're going to focus on what we can change.
I arrived here today for a totally different matter, but then this came to our attention. So it apparently just came out of committee this morning. And then we're going to turn around and vote on it this quick.
Yeah, this is committee.
This is still committee.
Yes,
Okay.
This is where we're having the discussion.
A lot of misinformation, and I haven't. I was told that it was an ACOG recommended thing, and it's really not. Just because.
Well, we have worked with ACOG and the Right to Life, and we have agreed upon language in this bill. So I'm going to move on to your colleague and allow you a few minutes to.
I do want to ask the question. So, okay, you're going to amend. You're going to get this better than what it is right now over the course of. And
right now, what we're going to do is hopefully we are going to implement this law, and we are going to see, if this actually affects positive change in the medical community. And, we can always come back in another session and make changes if we need to. But we need to give it time to work. So are you Dr. Rigby?
Okay, Dr. Cynthia Rigby, retired OBGYN, member of ACOG, and although I respect Dr. Goldberg, I can't accept the fact that he's speaking for Kentucky ACOG because he has not consulted with the physicians who practice OB here. Generally, our section has not had regular meetings for quite a while. So his opinion, as he stated, is against ACOG national policy. It muddies the language. I am at the university on the alumni council. I deal with medical students every day. I'm aware of the fact that time is not helping us because the people you train in the state will not practice here. We've lost most of our residents at U of L, and I can't get information from UK. But it is not an environment where OBs want to be second guessed by people who are not medical, especially in a litigious state. And it's not just the OBs. It's the people who are practicing pediatrics because they have adolescent patients. It's people who are young and have families. And as much as people didn't talk about miscarriages before, they happen, and they happen a lot, and people are being open about it. But if you are in a situation and you are making a family, you don't want to put your life into the hands of someone who doesn't have the training to deal with you or is hampered by that. So this is not helping the language, and the amount of time it's going to take to change things in this state is going to drive the practitioners we need to take care of our citizens to other places that are more favorable.
We're trying to address that. So I appreciate your comments very much. I'm going to ask our original presenters to come back to the table. Thank you so much for
Could
being
I ask
here
one
today.
question? How long does it take to change the wording in this? If this passes, how long would it take? 5 years? It's taken that long? 5 years?
We'll address that after this
Thank
is
you so
implemented.
much.
Thank you.
And I can address that right now.
Okay.
So continue it. The conversations will continue immediately. As Dr. Goldberg has mentioned, this group has gotten together, I think, for the first time in this way, and will continue starting. Hopefully, we can get a breath the first week of April, but the second week of April, we'll continue. Hey, what do we learn? What can be improved? I mean, we have to understand that. I know that some people want elective abortions, that my friends that have just spoken do. There's a baby involved, and that's not going to pass this General Assembly. And so, and I certainly wouldn't support it either. And so we're trying to solve this discrete issue that is a real and present issue and a real and present danger to women who are presenting with their lives in jeopardy today in our hospitals.
I think I also want to add too, when Dr. Goldberg started talking, he said that when we originally started talking, there was a lot of wariness and distrust from everybody's perspective. And I think we'll continue having that wariness and distrust, even though we've looked at each other in the eye and we are trying to work on making these laws as palatable as possible in order to make sure that the women here in Kentucky are safe. But I think that we'll still have those very strong discussions, and we'll still be able to protect both sides at the same time. So I again appreciate the wariness and distrust of some of you that are in the room. I do that. I understand that because I still have that concern as well. But we'll continue having those conversations, and we'll continue to make this Kentucky a great place to live. So thank you.
I was just going to add, I want to thank the members of the committee, and no matter where one rests on the issue of abortion, intentional abortion, I think remind us this is clarity language and much needed, and the definitions and the terms used we're all sitting around the table putting that together in conjunction with where we thought we needed to go for Kentucky women and for the physicians that care for them. And that's what's most important right now. And I think no matter where one might rest on the sides of, let's say, intentional abortion, wanting the best for Kentucky women and the best maternal health care for them at this point is where we need to be. And when Dr. Goldberg and I spoke, and being an OB nurse, and when he said, when someone mentioned that they had someone waiting, we don't want anyone ever waiting to see if one spikes a temperature to go on with the procedure. We want to make sure that their medical needs are immediately addressed. So I just wanted to mention that and thank all the members of the committee.
Thank you. Thank you very much. Okay. See no further questions. DJ, please take the roll. Oh, do we have a, yes, thank you. We have a motion and a second. Now, DJ, please take the roll.
Representative Bratcher. Representative Bray. Representative Burke.
I'd like to explain my vote. I do believe that there is a consensus, and I'm grateful for the consensus, that the current climate for doctors is untenable in a way that is imperiling the lives of Kentucky women. So I'm grateful we're finally all on the same page that our current laws aren't cutting it. This is at best a rough draft. And part of the reason it is at best a rough draft is because not everyone was at the table. And in spite of asking to have a seat at the table, there are people in this room, including myself, who did not get one. So this is just unacceptable because it muddies the waters. We need hospital general counsel to weigh in. Those are the people who are telling the doctors they can't act. So unless they're at the table, we don't have a solution. They are willing to participate. I have reached out to and talked to general counsels today. So the fact that they haven't been included isn't a reflection of their willingness to be included. If this would solve the problem, I could get aside from all of my other feelings about this issue. But the problem is that it doesn't solve the problem we're trying to fix. I don't want to put a bad bill through just to say we finally fixed it, only to have to wait a year and see that we failed to do what Kentucky women, what our doctors needed us to do, and what the Commonwealth requires. I'm a no.
Representative Callaway.
Briefly explain my vote.
Yes.
I'm an aye on this, a yes. And I want to thank the sponsors and those who've come to the table to have these discussions. They are tough discussions. I do think it's going to save women's lives. I do think this has been the problem that's been presented to us repeatedly to solve, and we're doing that, and I appreciate that.
Representative Camuel.
May I briefly explain my vote?
Briefly.
Thank you. Obviously, I'm a no on this bill. I've heard a lot of things today, but I know that the voters of Kentucky voted overwhelmingly to protect access to the full scope of medical care, which includes abortion. This bill doesn't do it. And I know that the doctor mentioned that it's not a perfect bill, but felt limited by a 30-day session. I don't think that rushing to get something done, again echoing Rep. Burke, just to get something done, this is not the way to do it. And we're going to wait and see, and we're still going to have more women die. We're going to have more women get sick, and we could solve this by simply repealing the law that we have now. Thank you.
Representative Dotson. Representative Duvall.
Yes.
Representative Fleming. Representative Gordon. Representative Holloway.
Yes.
Representative Marzian.
Briefly explain my vote, Madam Chair. I'm a no. Again, the people did speak in 2022 and voted overwhelmingly to defeat Amendment 2. They were pro-choice. They want medical care between a provider and themselves, and not the legislature sitting in the exam room. We're losing medical students, we're losing residents, we're losing pediatricians. It may not hurt Louisville or the urban areas, but rural, you all are going to suffer. And women are going to die out there. Hospitals are going to be a mess. This is clear as mud. And I vote no.
Representative Neighbors.
Yes.
Representative Proctor.
Yes.
Representative Rayburn.
Yes.
Representative Raymer.
Yes.
Representative Riley. Representative Sharp.
Aye.
Representative Wilner.
Explain my vote.
Yes, ma'am.
Thank you. I'll be voting no today. I want to say I really do appreciate the spirit of trying to address this concern. I'm to Dr. Goldberg. I hear these concerns from physicians all the time. I think that when we debated the trigger ban on the House floor, I brought up these concerns that this was going to leave a really unclear landscape for healthcare providers, and it has. If I thought this was the fix, even though it doesn't go as far as I would like it to go, if I thought it was the fix, I would so happily vote for it. I'm not convinced, having not heard from hospital attorneys. I'm not convinced that this protects doctors, and I'm sure that it does not protect pregnant people. So sadly, I'm a no today. Thank you.
Chair Mosier.
Yes. Okay. House Bill 414, as amended by the committee substitute, passes with favorable expression. The same should pass on the House. Thank you so much.
There's a title amendment.
Yes. Thank you. We have a motion and a second on the title amendment. All in favor of adopting, please say aye.
Aye.
Any opposed? Okay. Thank you.
Thank you.
All right. At this point, I will hand things over to my vice chair. I need to see if I am still speaking in banking and insurance. And we will take up Senate Bill 27.
Senator Storm, if you would, state your name for the record and have your guests introduce themselves.
Thank you, Mr. Chairman, members of the committee. Senator Brandon Storm.
Jane Rice Williams.
I think we have a committee sub. All in favor, say aye. Any opposed? Motion carries. Please proceed.
Thank you, Chairman, members of the committee. What we have today is Senate Bill 27, which is legislation to establish a Kentucky Parkinson's Disease Research Registry. And at the outset, I wanted to point out to the committee that pages 1 through 8 of the sub, all the way down to line 23, are my original bill, and so I can address those now. And so basically what we did, we worked with, Jane here is with Parkinson's in Motion, and so we worked in conjunction with the Michael J. Fox Foundation, the University of Kentucky, University of Louisville, Norton's, and St. Elizabeth's, and we came up with this agreed language, and it would establish an advisory committee, and those advisory committee members are listed on page 2, and it contains a neurologist, movement disorder specialist, primary care provider, physician, a person living with Parkinson's, a healthcare professional, individuals that are familiar with research, a Parkinson's disease researcher, a representative from the University of Kentucky College of Medicine, and the University of Louisville College of Medicine. What's important about this legislation is these demographics that we're trying to gather are going to be non-identifiable. So individuals who are participating in this, they won't have their names, their social security numbers, anything like that collected. Patients also on page 4 are able to opt out of this program.
We have a motion and a second. Would you like to proceed, or? All right. Do we have any questions? Okay. Yes, please proceed. Representative Burke.
Thank you. Just one question, and it relates to the sub. What is the role of pediatric extended care centers in the care for people with Parkinson's? I just wasn't sure how the pediatric care centers got rolled in.
That might be something for Representative Bratcher. You come to the table.
There's a sub that was put on there to allow pediatric cancer children to get transportation to a pediatric care unit.
Thank you.
All right. Any other questions? All right. Very good. DJ, please call the roll.
Representative Bratcher.
Yes.
Representative Bray.
Aye.
Representative Burke.
Aye.
Representative Callaway.
Aye.
Representative Camuel.
Yes.
Representative Dotson. Representative Duval.
Yes.
Representative Fleming. Representative Gordon. Representative Holloway.
Yes.
Representative Marzian. Representative Neighbors.
Yes.
Representative Proctor.
Yes.
Representative Rayburn.
Yes.
Representative Raymer.
Yes.
Representative Riley. Representative Sharp.
Aye.
Representative Wilner.
Yes.
Chair Mosier.
All right. Senate Bill 27 passes with favorable expression. I think we have a title amendment. Second. All right. All in favor say aye.
Aye.
Motion carries. Very good. Thank you.
Thank you so much from the bottom of my heart. I appreciate this.
All right. Next, we have Senator Berg coming to the table with Senate Bill 93. Senator Berg, please state your name for the record and
Good afternoon. My name is Karen Berg. I'm Senator from District 26.
all right. And I think we do have committee sub number 3.
Number 3. Yes, that's where we have landed.
Do I have a motion?
Motion.
Do I have a second? All in favor say aye.
Aye.
Any opposed? Motion carries. Please proceed.
All right, thank you. I'm going to try to be very quick, but I do have two
Oh, we have guests. Yes.
amazing women who
Okay.
want to speak. So I'm going to let them go first.
Yes. And please introduce yourselves, please.
Okay, yes. My name is Jennifer Hughes. I'm a parent of a 5-year-old who was born with hearing loss. His name is Everett. So the bill today is trying to support the lack of, right now we have lack of adequate coverage for pediatric hearing aids. So the bill today is trying to improve that. My experience, when Everett received his first pair of hearing aids, he was 2 months old, and we noticed an immediate difference in his ability to access sound. He's able to interact with his peers. He has that opportunity to be successful. I talk about he's in kindergarten now, and he recently received a Math Excellence Award as in a high-level phonics class. And that access to sound that he gets through his hearing aids is because it lets him be successful and gives him that level playing field educationally. So the challenges that we face, of course, is the inadequate coverage for hearing aids. Whenever it was 3, his audiologist recommended upgrading his hearing aids to a pair that cost $5,000. We understood our insurance benefit at the time that once we met our deductible, insurance would cover 50% of the allowable. We later learned the allowable was only $1,000 per year, and that it's common practice to balance bill the patient the difference between the cost of the hearing aids and what's allowable by insurance. So in the end, we paid the full $5,000 for hearing aids. Only $2,000 of that went towards our deductible and out of pocket, and the insurance didn't have to pay anything. So we're here today just for support for Senate Bill 93 to help strengthen legislation to help alleviate those financial barriers around pediatric hearing loss and allowing these children access to sound. Thank you.
My next.
Hi, I'm Shelly Motes. I'm a pediatric audiologist. in
Shelley,
Louisville.
Shelley, I hate to jump in.
Hi, Senator Berg. Thanks for
Hey,
having us
we
back.
just had a
today.
motion on the bill, so we can be quiet for a second and let's see if they want to proceed.
Audio didn't come through.
Thank you, though. Thank you.
Do we have any questions? Seeing none, DJ, please call the roll.
Representative Bratcher. Representative Bray.
Aye.
Representative Burke.
Aye.
Representative Callaway.
Aye.
Representative Camuel.
Yes.
Representative Dotson. Representative Duval.
Yes.
Representative Fleming. Representative Gordon. Representative Holloway.
Yes.
Representative Marzian. Representative Neighbors.
Yes.
Representative Proctor.
Yes.
Representative Rayburn.
Yes.
Representative Raymer.
Yes.
Representative Riley. Yes. Representative Sharp.
Aye.
Representative Wilner.
Yes.
Chair Mosier.
Yes.
Very good. Senate Bill 93 passes with favorable expression, and we do have a title amendment. All in favor? Aye. Any opposed? Motion carries. Very good. Congratulations.
Thank you very, very much. And to Shelley, thank you for being here, but we're good. Thank you.
Thank you so much. Oh, yes. I would like to record a yes vote on Senate Bill 27, please. Is there anyone else who needs to record a vote? Okay. All right. The next bill we will take up is Senate Bill 132. Senator Douglas, if you can make your way to the table and bring your guest, and everyone should introduce yourselves for the record and proceed with your testimony.
Thank you very much, Madam Chair and members of the House Health Services Committee. My name is Donald Douglas. I'm District 22 State Senator.
Hello, my name is Wanda Calvin, a physician with primary care.
I'm Greg Chaffwin, Senior Counsel with Alliance Defending Freedom.
William Werman, physician, emergency medicine.
Lindsay Cox, current emergency room nurse.
Madam Chair, in the interest of time, I had some things I was going to say, but I'm going to let some of my other folks go ahead and speak. But first, I'd like to say Senate Bill 132 is simply a common sense bill. And I know there are a number of you who received texts, emails, and likely even some phone calls about Senate Bill 132 out of fear. After my presenters speak today, what I'd like to do is tell you what this bill is and what this bill is not. But first, I'd like to turn it over to.
As a registered nurse, my career was impacted by a lack of conscience protections. When I was a student in nursing school and I was deciding what specialty I wanted to enter into, I changed the direction of my career. I planned on entering into women's health, which is something I was extremely passionate about, but due to fear of ethical concerns about being forced to participate in procedures that would violate my conscience, I changed that direction. I hesitated because I have learned of certain procedures that I might be forced or coerced to participate in. As a citizen in Kentucky, if I knew that my rights were protected to have sincerely held beliefs as a medical provider, I would have been free to choose a career path without fear of being kept out or having to violate my sincerely held beliefs. As medical providers, we're the same as anyone else. You and me, we all have beliefs that we've been raised with. And when I entered into medicine, I brought those beliefs with me. And I would just ask that as I continue my career, as I pursue further education to become a nurse practitioner, that I would get to take those ethical and moral beliefs with me. Thank you.
Hello, my name is Wanda Calvin. I'm a primary care physician in Louisville, Kentucky. My roots in Kentucky are deep. I grew up in Jessamine County, went to college in Kentucky, went to medical school and residency at University of Louisville, and currently practice as a primary care physician in Louisville. Some of the challenges as in being a PCP revolve around the ethical questions that I get asked by my patients. This happened recently when one of my patients made an unusual request. This precious person is a recently retired provider who has been diagnosed with mild cognitive impairment, MCI, which you could describe as mild pre-dementia. She, having previously practiced medicine, was really spiraling with this diagnosis and asked me if I would be willing to prescribe physician aid in dying. I was taken back by her request, especially because of the mild degree of her current state, but proceeded to ask her why she felt like she was ready to die. We spent the next 40 minutes unwrapping her fears, her hatred of the idea of a stranger taking care of her in a memory ward, and her preference to die when she still had her memory intact. While I had empathy for this request, I could not agree with a clear conscience. This is because I believe in the preciousness of human life. This belief is shaped by several things. First, that we're all created in God's image, and that disability or change in one's function does not make them less precious. Second, I made an oath to first do no harm, and this request would violate these two principles. I do believe that before God, I do not have the authority to volitionally end someone else's life. I think there are many measures of comfort, dignity, prevention, and treatment that could be given in this situation. And but I would not feel with my conscience that I could end her life. However, with the ever-changing climate of our culture, I fear that in the near future, I may not have the same freedom to operate according to conscience. If I was reprimanded or required to fulfill this request, I would be forced to consider leaving this profession that I love. My ask today is that you choose to protect providers like me who do love their patients, practice with excellence, and seek to do good to our community in Kentucky, and protecting our conscience, our right to practice according to conscience allows us to do so. Thank you.
Dr. Bill Werman, thank you for this opportunity to speak to you. So my emphasis here is to clarify the healthcare professional shortage that is present in Kentucky from my experiences, and also my support for this bill. So 19 years of emergency medicine, mostly in central Kentucky area, and I've seen not having enough doctors for mid-shift, not enough specialists to care for the patients that present to us for help, and resultingly needing to transfer these patients, and not being able to get them speedy help. And those specialist deficiencies include GI and interventionist cardiologists, and you all possibly are familiar with that, but also like paramedics, we're short on them and being able to transport. So shortages are real, and patients tell me then also they can't get into their primary care within a reasonable amount of time. So it's real, and I think this bill would help to bolster that situation. I myself have not experienced being forced to perform a procedure that I felt violated my conscience. But I do also represent the Catholic Medical Association and the Kentucky members, physicians, medical students, nurses, and others in this state. And I represent them in their support for this bill, that it would provide protection that they believe they need. So in summary, I believe that passing this legislation will have a positive effect on addressing the Kentucky healthcare professional shortages, as well as on the lives of healthcare professionals, and ultimately result in the best possible healthcare for patients. Thanks.
Madam Chair, as Senior Counsel with Alliance Defending Freedom, in my position, I routinely review legislation that affects civil rights, including the fundamental right of conscience, which is what this bill addresses. And just I'll raise a few important points about the bill, and then I'll be available for questions if they all might have. So very important to know that this is about not forcing doctors into doing a procedure that violates their conscience. This is not a conscientious right to do whatever they want to if their conscience tells them. It's just not forcing doctors into something that they think violates their sincerely held religious or ethical beliefs. Second, this is about a particular procedure or service. This in no way can be used on the basis of anybody's characteristics, their traits, or even their lifestyle choices that might have ended them up in that doctor's office that day. It has to be something conscientious objection about a particular procedure itself, as we've heard some examples of assisted suicide, for example. I would note that this works in practice. 6 other states have legislation like this protecting conscience rights for doctors, in one case for almost 20 years, and it works, and it's not overused. There are seldomly ever cases where this is applied, but that's as intended. Guardrails are meant to ensure that conscience rights are protected. You don't mean to run into the guardrails. They're there for your protection, the conscience rights of doctors. And it's very clear that does not apply to emergency medical situations. Federal law protects that, and this does not allow for conscience objections to that, which also makes sense because life-saving procedures are not the kinds of things that doctors have conscientious objections to. And just to wrap up, I would just note the 2 things that this also benefits: patients and the practice of medicine. We have healthcare professionals here, but patients also look for providers that can have a conscientious right. They want ethical integrity. They don't want their doctors to be forced into doing something that they think is wrong. In order to have a second opinion, you need free speech and conscience rights for doctors so that you can find somebody that might have another opinion. So this bill helps them. It helps the development of medicine because you need the scientific method of doing tests, reviewing those, and then repeating them. Part of the review is asking questions, not just about did the test actually lead to the outcome, but are there ethical concerns involved? And without that ethical consideration, obviously we can do many things, but we need doctors free to ask, should we be doing them? So this just protects their right to ask those questions and not be fired, as unfortunately was the situation of a professor here in the state of Commonwealth of Kentucky. But with that, I'll leave it there, and I'll be available for any questions.
Madam Chair, this bill, as well as to the Health Services Committee, This is not a bill that challenges our social structure. This is not a policy bill. And my goodness, this is not a free get out of jail free for some of those healthcare providers. They'll be very rare who might not want to do what they really need to be doing in medicine. The onset of corporate medicine has changed medicine. And this is something that we really don't want to talk about. When we look at private practice, although money was a big deal, the bottom line in private practice was the outcome, medical outcome for your patients. Corporate medicine has a different model. I'm not criticizing their model at all. And I don't want you to think that. But they have investors and they need results. And those results are cash flow. So we have physicians, we have healthcare people who are being asked, you either do this or you can no longer practice here and we'll find somebody else who does do this. And for those who think this doesn't occur, it's generally because you are not in the system. You're listening to the fears that everyone else is bringing. Some have suggested that we, in the healthcare space, have all of these protections at the federal level. But if you really go look at the federal legislation, what it talks about, if an institution violates your civil rights, the federal government has the right to withhold money from that institution until you correct those violations. It says nothing about the civil rights of the healthcare worker who has been harmed. And if you go look at the number of cases that have come up, very few. There's only like 3 or 4. And those institutions got their money back when they said, oh, you know, we've fixed everything. My argument here is that whether we like it or not, healthcare workers are citizens of this country. They are citizens of this Commonwealth. They don't deserve to be treated different. They don't. We don't. This is a healthcare recruitment bill. This is a bill for economic development. I have 3 kids who are practicing medicine in 3 different states who won't come to Kentucky.
Okay, we have a motion and a second on the bill. We do have one question from Representative Wilner. I'll allow that. And then we have some people who are signed up to speak for and against this bill. But Representative Wilner.
Thank you, Madam Chair. And I have to say my questions shifted continuously during the testimony. I had a lot of them. Some of them were answered. But it has become, the conversation continued, it's become less and less clear to me what we're actually talking about here. I heard you, Doctor, give a very specific example of physician-assisted suicide, which of course is not legal in Kentucky, so no one is going to compel you to do that, and in fact, you could lose your license for doing it. I heard you say that this would not prohibit anyone from getting emergency treatment. I heard you say that no one would be prohibited from getting health care based on who they are. So if someone, decides they don't want to treat women, they can't do that. And then I hear lots of vague things about these terrible things that you're being forced to do, and I don't know what they are.
Madam Chair. And you're right. People who are in the healthcare space don't know what they are. Unfortunately, I'm losing hair. I've only been in the healthcare space now for about 43 years, a long time. I'm an interventional anesthesiologist. I can't tell you the number of my colleagues who it was suggested that they do certain types of pain implants that they knew wouldn't help the patient. But the owners of those clinics said, if you want to work here, if you want your bonus, you better put this implant in or you lose your job. That's real. Ordering more tests, that is real. Being asked to do certain procedures that others aren't quite comfortable with, but we need you to do this, and you know, the patient won't know. And we can argue all day whether or not that's malpractice. But I would also argue it's malpractice if you get caught, right? Is speeding really speeding if you don't get caught? But that doesn't make it right. All we're asking here is that our healthcare workers have the same civil rights in practicing their jobs as started back in 1964 with the Black movement, as earlier people were arguing about for women. We're not asking for something extra, Madam Chair. This bill is not asking for anything extra. It's asking, could we have the same provisions as everyone else? Especially since we are the ones who spend all the nights not sleeping, all the nights studying, all of those nights going home wondering if we made the right decision regarding that particular procedure for that particular patient. Unless you've been there, it's hard to imagine. And I know your chairman has been there. Thank you, Madam Chair.
Thank you. I do agree. There are situations that you can't always describe until you're put in that position, and so I think you explained it very well. We do have another question from Representative Fleming.
I think the senator gave me some good examples to give me some clarity and an understanding of what the situations you are coming across. I just have one, clarification question. If a healthcare provider is in rural part of the Commonwealth, and I know the other doctor mentioned about workforce and issues, and I'm right there with you. But if there is a non-emergency procedure or situation that needs to be provided, and the healthcare provider doesn't want to do that, what does that person do? You understand what I'm saying?
You want to answer it? I'll be happy to answer it. Go ahead. Representative Fleming, that's a really, really good question. I don't know that happens. If it happens, it's very, very rare.
Okay.
And one of the things I will continually say is that no matter what we do, we can't legislate goodwill, and we can't legislate honesty. And this is not a perfect bill, and I'm happy to keep working on it. But that person has to deal with that. At some point, I would like to share with you some of the experiences that I have had in my journey through the healthcare system. I don't want to do it here, but I'm happy to share that.
I appreciate it. Thank you.
Okay, thank you. We have some folks who have signed up to speak. I will bring you up in threes because we have quite a few. Give you a few minutes each to explain your point of view, and then we'll bring our original panel back to the table. Emma Curtis, Serenity Johnson, and Eric Russ. If you can come to the table, please introduce yourselves for the record. And is Mr. Russ not here? Do you want to give 3 minutes or 2? 3. Oh, 2 per. Okay. 2 each. Mm-hmm. Brenda Rosen, are you here? Okay. Go ahead and introduce yourselves for the record and proceed. I'm going to give you each 2 minutes to tell us why you're here and why this is important to you.
Thank you so much, Chair Moser, and members of this committee. My name is Emma Curtis. I'm from Lexington. I happen to serve as the councilwoman for the 4th District, and I am a constituent of Senator Douglas's. We share about 25,000 or so constituents, actually, in our public service, and I've gotten to know him over the course of the past couple of years. And I appreciate the intention behind this bill, but I want to tell you a little bit about my experiences, because as written, this is not a bill about medical professionals being forced to provide care that they disagree with, morally, religiously, what have you, whether that's gender-affirming care, abortion, or anything else. And I want to say right off the bat, candidly, as a trans person, if a medical professional doesn't want to provide me gender affirming care, I don't want to be receiving gender affirming care from that medical professional in the first place. What scares me about this bill is that I, in my life, have experienced chronic medical conditions. On my 26th birthday, I was actually in the emergency room with a life-threatening event as a result of one of those. My partner had rushed me to the ER, where as an otherwise healthy young adult, I was admitted with a resting heart rate of 178, and I was in the early stages of liver failure. The timely care that I received in that day saved my life, but the care that I've received since has also saved my life. And that has nothing to do with gender affirming care, has nothing to do with my existence as a trans person. But the way this bill is written creates enough ambiguity that if it were law at the time, any of the providers who treated me could have denied to provide that care, that specialized care in that specific field for my specific condition, which is unrelated to the gender affirming care that I receive, solely on the basis of my existence as a trans person. And nobody's career is more important than another person's life. So I would ask the members of this committee to consider whether or not you believe it acceptable for those providers to deny me that specialized care. And, you know, when doctors graduate, they take a Hippocratic oath to do no harm, to commit their medical knowledge to help the sick, not only to help the sick that they personally like or don't disagree with. If they cannot abide that oath, they need to provide a new profession. They need to find a new profession. This bill creates so much more ambiguity. It is half-dash at best. If I appreciate, again, the intention behind it, but this bill does not accomplish the stated goals, and I urge you to vote no today.
Okay,
Thank you.
Serenity?
Afternoon. My name is Serenity Johnson, and I am a proud resident of Hardin County, Kentucky. I'm going to start by saying healthcare isn't just about the providers. It's also about the patients. And especially after hearing the testimony in favor of this bill, I'm getting ever more convinced that it's a Band-Aid, and the solution that it's providing doesn't really even address the issue it's trying to Band-Aid. I'm going to rewind a little bit real quickly. About 15 years ago now, I was up all night with excruciating abdominal pain. Ended up going to the hospital the next morning, and long story short, I'm here testifying before you without an appendix. It would not be an exaggeration to say that my surgeon saved my life that day. Now, I had not begun to transition at that point as a transgender Kentuckian, but as somebody who was in so much pain, imagine the doctor coming to my room and saying, "We're sorry, but we can't help you because we think that this procedure in your case violates our sincerely held beliefs." And the way that I've seen the bill as it's written, I think it provides just too much wiggle room for that kind of thing. I know that this is a more serious example than most scenarios, but even in less serious, everyday provided care, early care helps prevent more serious issues later on. Objections to procedures should be rooted in medical necessity, not just personal convictions. Our healthcare providers and their staff have an obligation to help people. It's true that we have a healthcare provider shortage here in Kentucky. It's something we talk about constantly. And it's true that we have to address it. But this bill, as it's written, does not do that. Not at all. It endangers people, it endangers Kentuckians, and it's only going to hurt our Commonwealth. I ask the committee not to advance this bill. Thank you.
Thank you. Brenda?
Oh, thank you. Hi, my name is Brenda Rose, and I'm the Executive Director of the National Association of Social Workers, and I'm here also to oppose this bill. There's a couple of different facets to this bill. I do agree that corporation in healthcare is an issue, and I think ethically that is something for conscience that we do need to discuss, but that's separate from when we look at a procedure. Because with every procedure, there's a human being behind that. And my fear is that what we're doing here is allowing the, if you will, the kind of emotional luggage that we all pack up every day before we head to work, that has our morals and our values and our whatever faith beliefs that we have, those things they should not be in the room with a client, with a patient, when our focus needs to be on patient care. I spent 30 years as a medical social worker. My husband is 45 years and counting as a physician. And when we had these conversations, his response was, you know what, if you can't see a patient as a person, and if you can't see the things that you went to school to learn to do, the expertise and the licensure, if you can't see that your own stuff is not part of that at all, your goal should be taking care of your patients. And to me, that's missing in this bill. And I want to address, the lovely young woman who talked about her patient wanting assisted suicide. If I had $1 for every hospice patient of thousands of hospice patients that I've worked with who asked me that same question, I'd be sitting in the Bahamas drinking a Mai Tai right now. But that's where we as healthcare providers need to rely on our team. And I feel if we have people that say, I can't do that because it goes against my own beliefs, that we're shortchanging a healthcare in a state that is so desperate for healthcare providers. This bill is called the Healthcare Heroes. Those are the people that worked and died to keep us alive during COVID. Those are the people that had to leave the state because they didn't want to compromise the care they're not able to provide here in Kentucky. Shout out for changing a lot of those things so we can get more people here to take care of us. Our rural areas are just dying because of lack of physician care, even in our big cities. So a bill like this terrifies me because our own stuff needs to stay in our own place. I learned more about my faith and about my morals working for years with people of all different walks of life, of all different religious beliefs, of all different morals. I've sat in basements with swastikas hanging on a wall. You know what? With a Jewish last name? Let me tell you, did I feel frightened? Did I say, I can't go in there? Absolutely not. I went in there and I did my job. And I think
Thank you.
That's
time
fine.
is up.
Great.
Yeah.
Thank you.
Yeah, thank you. Okay, we have a few others. Joanne Brown, you here? And Tamara Weeder and Chris Hartman. Go ahead and introduce yourself for the record, and I'll give you each 2 minutes
I'm right.
to
Hi.
tell us why you're here. Thank you.
My name is Joanne Brown. Thank you for the opportunity to speak with you today. I recently retired after a 44-year career as a nurse, 25 of those as a nurse practitioner. I am certified as a women's health nurse practitioner and a family nurse practitioner, and spent the majority of my practice providing reproductive, women's, and gender-related health care. SB 132 in its current form will open the door to discrimination by allowing healthcare providers, whether they be individuals or institutions, to withhold evidence-based care or information, or to simply deny care based on their objection to the patient themselves. Throughout my career as a nurse, I have countless stories of the impacts of such denials. I witnessed other nurses refusing to provide care for patients with a much-desired pregnancy who are admitted to labor and delivery for pregnancy termination due to fetal anomalies incompatible with life, or because the mother's risk for major health complications or even death if the pregnancy continued. As a nurse practitioner, I saw patients denied access to birth control and other reproductive health care services in their communities by the only physician or pharmacist in their county, as well as many others who were stigmatized and denied care because of their age, sexual orientation, or gender identity. I had patients forced to travel to a different county because their local pharmacy would not fill a prescription I wrote for them providing evidence-based care such as PrEP or gender-affirming hormones. While these may have been isolated cases in the past, legitimizing this discrimination will cause greater harm. The Nursing Code of Ethics outlines that laws such as SB 132, which restrict or impede individuals' rights to care, are not congruent with ethical practice, and in not respecting patients' rights and dignity, threaten patient safety. As a young nurse, I assumed all healthcare providers would put aside their own biases to provide ethical, evidence-based care But unfortunately, that is not the reality. Please vote no on SB 132.
Thank you.
Good afternoon. My name is Tamara Weeder. I am the State Director for Planned Parenthood Alliance Advocates here in Kentucky, and we are here in strong opposition to Senate Bill 132. When healthcare providers are allowed to deny care and information, patients are put at risk. This bill allows delayed and substandard medical care with no protections to ensure patients get the care they need. This will harm Kentuckians, especially people who already face barriers to accessing care, such as people with low incomes or people living in rural areas who can't easily obtain care elsewhere. All people in Kentucky should be able to access the care they need it when they need it, without fear that their provider will withhold evidence-based care or information. This bill is so broad that any person who participates in any healthcare service in any way could object essentially for any reason, so long as the person claims it goes against their moral beliefs. A pharmacist could refuse to dispense antidepressants. A receptionist could refuse to admit a patient experiencing a life-threatening miscarriage to a hospital because they do not want to participate in end-of-pregnancy care. A physician assistant could refuse to provide certain types of birth control. An ambulance driver could refuse to take someone to the hospital because they are a Republican or because they own a gun, which violates their morals. This bill even allows people in institutions to deny care based on their objection to the patient themselves, such as denying contraception to an unmarried woman or refusing to provide pediatric care to a child with gay or lesbian parents. Freedom of religion is important, but religious freedom does not include the right to harm and discriminate against others. Moral objections of healthcare providers cannot be prioritized over patients receiving the care they need. Leaders in the healthcare field, such as the American Medical Association and the American Congress of Obstetricians and Gynecologists, oppose this type of legislation because healthcare providers have a duty to prioritize their patients' interest and well-being. Senate Bill 132 is detrimental to our state and, more importantly, to the people in Kentucky. If enacted, this would be one of the most extreme refusal laws in the country and would have far-reaching consequences for patients seeking all kinds of medical care. Thank you.
Thank you.
Madam Chair, Mr. Vice Chair, members of the committee, Chris Hartman, Executive Director of the Fairness Campaign. Senate Bill 132 would simply allow discrimination and cause chaos in healthcare settings. It allows any hospital worker to refuse to perform key aspects of their job without repercussion, including prejudice, if they can justify it as not just a sincerely held religious belief. Hone in on the fact that you can use an ethical belief or a moral belief. Literally anything is what this bill opens the door to as a justification to refuse to do your job. And as the hospital or the doctor's office, you cannot move that employee. You cannot discipline them. You can't put them on a different shift or move them to a different floor, because if you do, under this bill, you'll be sued. And so who do you move? You can't move the employee. To speak to Representative Fleming's question, you move the patient. And certainly folks are going to say, and we've heard it, that emergency situations are exempt, but that's a little subjective. Because anything can turn into an emergency situation if deferred long enough. And if I'm a gay patient, which I am, who's been denied service somewhere, I'm going to be far less likely to seek it elsewhere. And this is why you see such dramatic high rates of cancer within the LGBTQ community. Because folks have experienced discrimination before. We've been turned away before. We know what this feels like. And so folks put off early screenings, and then they end up in dire situations. Federal judges have consistently struck down a similar HHS rule. I'll remind you that the majority of Kentucky voters oppose measures like Senate Bill 132, and I would just ask you to keep thinking about this one, because what the bill sponsor says he wants to achieve, this bill does not do. Thank you, Madam Chair.
Thank you. Okay, we have Nick Spencer with the Family Foundation. Do you want to make a statement? Please introduce yourself for the record, and then I'll bring everyone back to the table.
Thank you, Madam Chair. My name is Nick Spencer. I'm the Director of Policy for the Family Foundation of Kentucky. The Family Foundation stands in strong support of Senate Bill 132. We thank Dr. Douglas for his hard work on this bill. This is not the first session that something like this has been before the General Assembly. It's been a number of sessions of work. I want to be clear. Those that you have heard say that this bill would allow for a provider to deny service to someone who is homosexual because they disagree with homosexuality, or deny care to a Jewish individual because they are anti-Semitic, those who make those claims have not read Senate Bill 132 clearly. Senate Bill 132 does not allow for those sorts of claims. Okay. Again, Senate Bill 132, as Dr. Douglas was saying, concerns an objection to a procedure. Now, from personal experience, I'm not a doctor, but there is sort of an analogous experience that I've had. Previously, I served as a chaplain candidate in the United States Army Reserve as a commissioned officer. In the U.S. Army, in the chaplain corps, there are protections for the religious beliefs of chaplains. You go through what's called an endorsing agency, where you subscribe to a particular statement of faith, and if you are asked to do something that is outside of that statement of faith by an individual soldier, you have the right, in many cases your endorsing agency would say you have the obligation to reject to perform particular religious services. Again, I'm using that word service, based upon your own religious beliefs. And what's the result? Where are all the lawsuits for people who of different faiths that have been told by a particular chaplain that that chaplain is not going to provide the religious service that service member is requesting? They don't exist. It doesn't happen. And that's at the federal level. That's a federal protection. So there are instances, again, not exact, but analogous, that do exist that are in line with SB 132. It's not a danger to individuals. And again, it focuses particularly, especially on a service that is provided rather than an individual person.
Okay.
Thank you.
Thank you so much. Okay, if I can ask my bill sponsor and guest to come back to the table, if you want to just quickly address any of the concerns that have been raised. If they're, we do have a motion and a second on the bill, though, I will remind you. And I just want to say quickly that the KMA has, they are neutral this year, and that the AMA Code of Ethics really lays out how practitioners should behave in these instances. So is there anything that you'd like to add?
No, Madam Chair.
Okay, thank you. DJ, please take the roll.
Representative Bratcher. Yes. Representative Bray.
Aye.
Representative Burke. Representative Callaway.
Aye.
Representative Camuel.
May I explain my vote? Madam Chair, may I explain? Thank you. I'm a no on this bill today. I think it is a dangerous bill and opens the door for individuals to suffer in ways that should not happen at the hands of medical practitioners. And just to correct, I have read the bill, and it explicitly states, just for correction, that a healthcare professional or healthcare institution shall have the right to refuse to participate in any healthcare service. So it does allow anybody at any level to choose not to provide any service, whether it's administrative or medical. Thank you.
Representative Dotson. Representative Duval.
Yes.
Representative Fleming.
Explain my vote.
Yes.
Thank you, Madam Chair. I do want to follow up with the Senator on some more examples in terms of what you come across. On the other side of the coin, I understand that I didn't hear any hard examples of those situations that they've encountered. I assume they exist in that regards. But there is, and I do want to stress, like Medicare, healthcare professionals adhere to ethical standards. And if you violate that in any way, shape, or form, you're out. And so part of that I'm leaning toward that ethical standards, which I have to live by myself. And so I'm going to vote aye.
Representative Gordon, Representative Holloway,
Yes.
Representative Marzian, Representative Neighbors,
Yes.
Representative Proctor,
Yes.
Representative Rayburn,
Yes.
Representative Raymer,
Yes.
Representative Riley, Representative Sharp,
Aye.
Representative Wilner,
Explain my no vote.
Yes.
Thank you very much. So what I heard at the testimony table is very different from what I read in the bill. And I want to say that I'm come from a healthcare family. Healthcare providers should not be discriminated against. The examples you gave frankly sound like fraud. And if you feel like you can't report clinics for wanting you to bump up the bill, I think maybe we need to strengthen whistleblower legislation. But this is not the right vehicle, I don't believe, to solve the problem you brought us. I sympathize with the problem, but I'm very concerned about this resulting in all kinds of discrimination in healthcare, and so I'm a no today. Thank you.
Chair Mosier.
Yes. Senate Bill 132 passes with favorable expression. Same should pass on the House floor. Do you need to register? Oh, I thought you. Okay. All right. I will.
Thank you, Madam Chair, and thank you, Health Services Committee.
Thank you. Next, we are going to quickly talk about Senate Bill 153. So I invite my bill sponsor to the table, and I will join you.
All in favor, say aye. Any opposed? Committee sub is approved. Senator Richardson, if you'd state your name for the record and have your guest do the same.
Senator Richardson, representing the 3rd Senate District.
Darren Bibb, co-founder. Thank you. Darren Bibb, co-founder of StepWorks and board member of Kairos.
I am Kim Mosier, State Representative of the 64th District.
Please proceed.
I'll start with just the overview of Senate Bill 153. We've heard a lot of testimony today about imperfect bills. This is a perfect bill.
Second.
We have a motion. We have a second. Are there any questions or discussion? Hearing none, DJ, please call the roll.
Representative Bratcher, Representative Bray,
Aye.
Representative Burke, Representative Callaway,
Aye.
Representative Camuel,
I'm going to pass today. I have not had a chance to read the sub.
Representative Dotson, Representative Duval,
yes.
Representative Fleming, Representative Gordon, Representative Holloway,
Yes.
Representative Marzian, Representative Neighbors,
Yes.
Representative Proctor,
Yes.
Representative Rayburn, Representative Raymer,
Yes.
Representative Riley, Representative Sharp,
Aye.
Representative Wilner,
Briefly explain, I'm going to have to pass. I got the sub at 11:30
We-
and I just haven't.
we-
But I'm
we-
sure it's a perfect bill.
We
I'm
do
sure it's
have
perfect.
we do have a title amendment.
Motion
Is-
on title amendment.
all in favor, say aye.
Aye.
Aye. Oh, I'm sorry. I'm sorry. I thought you were finished. Sorry. Wait just a moment. Gentlemen, please wait just one moment. One moment.
Chair Mosier.
Yes.
All right. Title amendment.
It does pass.
Okay, that's fine. Okay. Very good. It passes with favorable expression. So, very good.
Now motion on the title amendment.
Now motion on the title amendment. Okay. Motion on title amendment. There we got. Okay. I think everyone had voted for that. So, motion carries.